I am Dr. Wilbert S. Aronow, Professor of Medicine at Westchester Medical Center and Director of Cardiology Research at Westchester Medical Center and New York Medical College in Valhalla, New York, USA. I gave a talk on July 28th at the 23rd World Congress on Heart Disease in Boston, titled Highlights of the 2017 American College of Cardiology, American Heart Association Hypertension Guidelines. These guidelines state that a normal blood pressure is a systolic blood pressure below 120 millimeters of mercury and a diastolic blood pressure below 80 millimeters of mercury. Increased blood pressure is a systolic blood pressure of 120 to 129 millimeters of mercury and a diastolic blood pressure below 80 millimeters of mercury and should be treated with lifestyle measures. Stage 1 hypertension is a systolic blood pressure of 130 to 139 millimeters of mercury or a diastolic blood pressure of 80 to 89 millimeters of mercury. Stage 2 hypertension is a systolic blood pressure of 140 millimeters of mercury or higher, or a diastolic blood pressure of 90 millimeters of mercury or higher. Using these new guidelines, the prevalence of hypertension in the United States of America in persons aged 20 years of age and older is 49% of men and 44% of women. And in persons who are aged 75 years and older, the prevalence of hypertension is 83% in men and 86% in women. In patients who have stage 2 hypertension or a blood pressure of 20 over 10 millimeters of mercury or higher above their goal blood pressure, they should initially be treated with 2 antihypertensive drugs from different classes. Patients with clinical cardiovascular disease, such as coronary heart disease, heart failure with preserved or abnormal ejection fraction, stroke, should be treated for secondary prevention of cardiovascular events if the systolic blood pressure is 130 millimeters of mercury or higher, or the diastolic blood pressure is 80 millimeters of mercury or higher. Patients with hypertension, patients who have no evidence of clinical cardiovascular disease, but their 10-year estimated risk of developing an atherosclerotic cardiovascular disease event using the atherosclerotic cardiovascular disease risk calculator is 10% or higher, should be treated with lifestyle measures plus antihypertensive drugs if the systolic blood pressure is 130 millimeters of mercury or higher, or the diastolic blood pressure is 80 millimeters of mercury or higher. If persons with no evidence of a clinical cardiovascular disease have an estimated 10-year cardiovascular risk of less than 10%, then they should be treated with lifestyle measures plus antihypertensive drugs if the systolic blood pressure is 140 millimeters of mercury or higher, or the diastolic blood pressure is 90 millimeters of mercury or higher. For white or other non-black adults with primary hypertension, the initial antihypertensive drug should be an ACE inhibitor or an angiotensin receptor blocker. If additional drugs are needed, they should be a thiazide diuretic, preferably chlorthalidone, or a calcium channel blocker. In white and or other non-black adults aged 60 years and older, the initial antihypertensive drug should be a thiazide diuretic, preferably chlorthalidone, or a calcium channel blocker, and if a third antihypertensive drug is used, it should be an ACE inhibitor or an angiotensin receptor blocker. In black adults with primary hypertension, the initial antihypertensive drug should be a thiazide diuretic, preferably chlorthalidone, or a calcium channel blocker, and if a third antihypertensive drug is indicated, it should be an ACE inhibitor or an angiotensin receptor blocker. Now, patients who have comorbidities, the choice of antihypertensive drugs depends on the comorbidity. For example, if you have coronary heart disease, the initial drug should be a guideline-directed beta blocker, such as either metoprolol succinate or metoprolol tartrate, or carvedilol or bisoprolol, or nadolol or propranolol or timolol, but you must avoid a timolol. Plus, in addition to the beta blocker, it should be an ACE inhibitor plus an angiotensin receptor blocker. If additional drugs are indicated, it should be a thiazide diuretic or an aldosterone antagonist. In patients who have heart failure with a reduced ejection fraction, they should be treated with diuretics, plus a guideline-directed beta blocker, which in this case is either carvedilol, metoprolol succinate, or bisoprolol, plus either an ACE inhibitor or an angiotensin receptor blocker or an angiotensin receptor neprilysin inhibitor, and if indicated, an aldosterone antagonist. For patients with heart failure with a preserved ejection fraction, their volume overload should be treated with diuretics. If hypertension persists, the drugs of choice are an ACE inhibitor or angiotensin receptor blocker plus a beta blocker, and if needed, an aldosterone antagonist. For patients who have had a stroke or a transient ischemic attack, the initial drug of choice would be a thiazide diuretic or an ACE inhibitor or angiotensin receptor blocker, and if a third drug is indicated, it should be a calcium channel blocker. For diabetics, the initial drug of choice should be either an ACE inhibitor or angiotensin receptor blocker, or a thiazide diuretic, or a calcium channel blocker. And if albuminuria is present, the drug of choice would be an ACE inhibitor. For patients who have had an ischemic stroke or a transient ischemic attack, the initial drug of choice would be a thiazide diuretic plus an ACE inhibitor or an angiotensin receptor blocker, and if a third drug is indicated, it should be a calcium channel blocker. Patients with a thoracic aortic disease, the drug of choice is a beta blocker. Pregnant women should be treated with methyldopa, nifedipine, or labetalol, and drugs that are contraindicated in pregnancy include an ACE inhibitor, an angiotensin receptor blocker, atenolol, or a direct renin inhibitor, because these drugs are fetotoxic. Non-dihydropyridine calcium channel blockers are contraindicated if the ejection fraction is reduced. And finally, an ACE inhibitor plus an angiotensin receptor blocker is contraindicated, and an ACE inhibitor or angiotensin receptor blocker plus a direct renin inhibitor is contraindicated.